So today we have an excellent presentation lined up with two excellent speakers and experts on proton therapy treatment of moving tumor, and both from UC Pennsylvania. And first is Professor John Plastaras. He's in the Professor of Oncology at UC Pennsylvania. Dr. Plastaras has been an expert, has published extensively, and is also international speaker for the proton therapy for several decades. He's actually did training at UPenn, and also since 2007 he joined the faculty at UC Pennsylvania, and he have served as the principal investigator for many clinical trials with proton therapy for GI and also for radiation therapy. And we are very lucky to have him at our speaker today. And with that, follow that, we also have Dr. Jennifer Wei Zhao, medical physicist, assistant professor, also from UPenn. Dr. Wei Zhao have received her PhD in theoretical and applied mechanics from Cornell. She did her master in medical physics at UC Penn before that. And after her medical physics residency in 2012, she have worked as assistant professor at Rutgers University, and then for the last 5 years, she has go back to UPenn and been there and have extensive clinical work and research on proton therapy and focus on the temporal effect of dynamic beam delivery and motion management. And with that said, I'm about to turn over the speaker to Dr. John Plastaras, and I want to ask the audience, please mute your phone and your video, and also please post all your questions on the chat box, and I will address it at the end of the presentation. Okay, yeah, thank you so very much.
All right, and again, can you guys hear me okay?
Yes, we can hear you well.
All right, yeah. So thank you so much, Juan, and thank you to the organizers for inviting us. Jennifer and I work together well, and we're really excited to sort of tell you our view of the world on using deep inspiratory breath hold for two sites. And again, these are sort of my clinical areas, GI cancers and lymphoma both. And I think that it's actually interesting because they provide, I think, sort of complementary looks at how deep inspiratory breath hold can be used both in the photon clinic and in proton clinics. So again, thank you for having us. So we'll kind of get right into it here. The outline I want to discuss is to go over kind of the two main reasons to even use breath hold. And in my opinion, this really is, motion control and to manipulate organ position. In the GI sites, I'm going to talk about liver tumors and pancreas tumors, which I think are probably the most valuable for deep inspiratory breath hold. And for the lymphomas, I'm going to spend a lot of time on mediastinal lymphomas, and then we'll touch on gastric molds, because I think it's kind of interesting as well. And then Dr. Zhao will do some of the technical considerations and explain some of the magic behind the scenes that happens with breath hold. So where do Jennifer and I come from, and where do we live? So we are fortunate to be at the Perelman Center for Advanced Medicine, where they built a whole building right on top of our Proton Center. So our Proton Center is sort of one long corridor, and then in the L of the corridor are 5 linear accelerators and an HDR room. And then we have PET CT simulators, regular CT simulators, 1 MRI simulator, and then the rest of the area where the clinic takes place. So the Roberts Proton Therapy Center is definitely an exciting place to work. We do have quite a large clinical capacity, and there is at the end of it a really cool animal research facility with a proton SARP, which is really being used to great effect for our lab colleagues. So again, the simulators we have 3 Siemens CT scanners and 2 that are dual energy, a Philips PET CT, a Siemens MRI, and then 2 varying acuity simulators for our simulations. And then on the treatment side, we have 3 variant true beams, 2 halcyon machines, And Penn was actually one of the beta test sites for Halcyon, so we've been using them for a while. And we may have specific questions about breath hold and Halcyon if you want to ask those. And then on the Proton side, we have the 4 gantry rooms and the 1 fixed beam room. So taking a big step back, why use deep inspiratory breath hold at all? I think, first and foremost, the obvious for motion management is that breath hold is just a great way of, limiting motion when you are trying to keep your target volumes small in moving targets. So that's kind of the obvious thing. When I first started out as a resident, I think it was a brand new thing for people to even realize that things inside the body really move. We started out with the fluoro simulator, so we actually got to see lung cancers move, and we, designed our 2D fields accordingly. In the deep inspiratory position, though, there are, I think, other particular advantages, and one is to actually try to deform your target. So in the case of mediastinal lymphomas, we'll talk about how you can narrow the mediastinum and create a smaller target. And then very importantly is the anatomic displacement of organs at risk away from the target. And then there's kind of a general concept of just changing the size or shape of organs. And the example of this is enlarging the lungs. So I think most places that have capacity to do deep inspiratory breath hold do so for this reason. So this is your classic left-sided breast cancer. And the paper that came out in the New England Journal that showed that mean heart dose correlates with cardiac events really put, I think, a lot of heat on the breast cancer people to get that heart out of their fields. And deep inspiratory breath hold is a great way of doing this if the patients are able to do it. You can move that heart back. And I want to thank Gary Friedman for this slide. So really, this is, I think, what drives most decisions to purchase breath hold equipment is to be able to treat a lot of breast cancer patients well. And so we have departments now with a lot of deep inspiratory breath hold devices lying around. So what else can you do with those? That's kind of what this talk is about. So in the GI side, I think there's certain aspects of treating GI cancers with radiation that are important to kind of just put out there. So GI cancer radiation really does require high doses, in particular higher doses than we've used in the past. This is both, I think, in unresected pancreas cancer, where we're seeing that doing dose escalation may be of value, and in liver cancer, where we're going to very high BED equivalents now, and finally are able to control HCC. I think in the past, we've kind of used piddling doses to treat liver cancer and pancreas cancer, and the results were expectedly bad. So, using technology, we can actually get those higher doses and be effective. So I think that's just an important point, that we really do look for those higher doses. That being said, those targets tend to be very close to important organs at risk, bowel, duodenum, et cetera. And our planning ends up creating very, very steep dose gradients to protect those structures. Unfortunately, a lot of the GI sites also move quite a bit. So the esophagus, GE junction tumors sitting right at the diaphragm bounce up quite a bit. Liver moves a ton. It moves with breathing and deforms quite a bit. And then the pancreas and the duodenum, even though they're retroperitoneal structures, they can move more than you might think. And I think that was one of those things that once we started putting in fiducials and watching the pancreas move, I think we're all sort of surprised how much the pancreas does move. And I think the key aspect of dose escalation in GI sites is that limiting motion really allows you to do that dose escalation. So if you look at the initial dose escalation work in pancreas cancer pioneered by Edgar Ben-Joseph when he was at Michigan, that was all with breath hold. And that was the thing that allowed them to do these really high doses to small targets because they weren't moving with breathing. I will say that, I don't really care if it's deep inspiratory or end expiration for that type of work. I think both can work. But when it comes to, clinic workflows, sometimes you just pick one and go with it. I will also say that the GI cancer patients are often sicker and are less able to do complicated breathing control. And I will say in our clinic, Our therapists estimate that we're kind of around maybe 50% of our patients are able to do the SDX breath hold machine. We don't necessarily try it in all of them. Maybe more could do it if we allowed them to even try, but sometimes you look at a patient and they're just not well enough and you say, I'm not even going to try to spend time. And so we end up doing a lot of abdominal compression devices for people we don't think are even able to do it. So counter that to lymphoma sites. In particular, I'm talking about mediastinal lymphomas, but I think many of the lymphoma patients that we treat with curative intent, we're going to be using lower doses. So doses ranging from 20, 21, 30. Sometimes I'll treat a patient with 36 or 40 gray, but I feel like that really gets spicy for me treating a lymphoma. Most of the OARs though are getting doses in that range because the fields tend to be quite large. Again, similar to GI, the targets do move, but they move in a little bit different way, and it's extremely dependent on the case and where the anatomy is. The mediastinal sites are interesting because if you take a deep breath, the mediastinum narrows. This is not unlike what happens when you treat a patient upright versus supine. So, Eli Gladstein, who's my mentor for treating patients with lymphoma, would always comment like, if you lay the patient on their back, their mediastinal mass is just going to pancake out. And it's like, you got to treat them upright on a chair if you can sometimes, So he was a big advocate for trying to manipulate the target. And I think that if he, really saw what we're doing with a deep inspiratory breath hold, he would have a large grin on his face. And the other aspect, as I mentioned, is the lungs do expand when you're treating mediastinal lymphomas. And so when you think about DVHs and the volume that gets a certain percentage, you're just dealing with a larger denominator. So you're treating a fractionally smaller amount of lung when you have a larger expanded target. So I think this is probably one of the most important uses of breath hold in treating mediastinal cases, for lymphoma. One of the other things that we see is that the heart gets pushed down and away from the target. And often people will claim that breath hold will give you lower heart doses. And as I've been alluding to, the mediastinum is probably one of the most important indications for using breath hold for lymphomas, but gastric malt is also an interesting indication, basically moving the stomach away from the heart. I will say, though, that we have occasionally used it in other retroperitoneal or mesenteric sites where we want to kind of limit motion. So let's move into liver cancer. So when I was a resident, I spent 4 years doing cases, and I think I treated exactly one liver my entire time while I was a resident. I will say that it has been fascinating to see the rise of liver cases that are treated with radiation therapy. So, I had to learn from scratch, as I think many of you also have. This is in the upper right-hand corner, the hepatobiliary new starts from 2011 to 2017 at Penn, dramatically increased. But we can see this in the NCDB. This is a study, Bitterman and colleagues, showing that the patterns of care using both external beam radiation and radioembolization have been rising considerably, since the early 2000s. And I think this is in part due to the technologies that our physics colleagues have, invented. So SBRT, proton therapy has increased our ability to attack tumors. And once we started using those high doses, we found that we actually can control hepatocellular cancer and intrahepatic cholangiocarcinoma. Some really important work by Ted Hong and his colleagues at MGH, I think really kind of moved the needle on what people thought radiation could do. And furthermore, we've seen an explosion in treating oligometastatic disease and radiation in general, and the liver is certainly one of those important sites. And if you guys remember our Astro a couple of years ago, there was big emphasis on oligometastatic treatment, and so this has been, I think, a real reason that we've seen liver cases booming, and therefore we have to learn how to treat them right. So This is the trial I was referring to before. Ted Hong did a multi-center trial of proton therapy for hepatic tumors, so both a primary hepatocellular carcinoma and also primary intrahepatic cholangiocarcinoma were both allowed on this trial. So they got 92 patients. We participated in this study, and they're treated with a hypofractionated course of proton therapy using 15 fractions up to a maximum total dose of 67.5 gray. This was scaled down if you ran into bowel or if you were a central tumor, but regardless, they treated with high doses, but not everyone got the same dose. And what we see here is that the control rates were, I think, much better than anyone would have expected. So the probability of local recurrence, hovering down here, in the less than 10% rate for HCC, and obviously a little bit higher for IHCCs. But the point is, I don't think people thought that we'd get results that good. And we saw that dose matter. So if you couldn't get in that dose above 60 gray equivalents, those are the patients that you saw the local failures in. So I think this is really important work showing kind of what the goals are in treating liver tumors, both HCC and intrahepatic cholangio. So as you guys all, realize that the liver is a major site of motion, the thing bounces up and down like crazy. And depending on individual patients' motion, even pretty small GTVs can end up turning into quite large ITVs if you just do straightforward 4D. The goal really is to get as much dose into as much of the tumor as you possibly can, and sparing the the rest of the liver, which often is diseased in HCC. We treat a lot of people who have cirrhosis, and we gauge that looking at their child Q scores or classes. And even some of the sickest patients we end up having to turn down just because we can't get the dose in without tipping their liver over the edge. But usually I'll say what we get limited by is the bowel, stomach, duodenum, and sometimes kidneys. I chose this case because I thought it was interesting because it also shows that a dome lesion that's quite medial can get you close to the heart. And this is the case that we actually treated with DIBH. And you can probably appreciate that the dose is being cooled off as you get closer to the heart. This white stuff in here is Lipiodol from prior chemoembolization. But in this patient, we also took a free breathing scan. And again, I didn't measure this out, and this dose is just where it would have been for breath hold. But I think you can appreciate that in free breathing, there's a significant amount of the liver pressing up against the heart. So, you try to work these angles and edges to try to pull the target as far away from the OARs as possible. May not have been as successful in this particular case, but I did want to point out the heart as an interesting organ that even though in the GI world, it's mostly about stopping motion, occasionally you might get a little extra benefit with the deep inspiratory breath hold when you're up near the heart. And so, the breath hold for liver cases, I think, can be challenging because these patients are often a little bit sicker. If they have, cirrhosis, they may have hepatic encephalopathy, so their brains aren't working quite as well, and they don't do as well with, breathing control. So we will, as I mentioned before, bring in the abdominal compression, or sometimes just free breathing if we can't do the abdominal compression due to these comorbidities. The liver is, very deformable. So, volumetric onboard imaging with CBCT is extremely valuable. That being said, one of the challenges we have with deep breath hold in CBCT imaging is that, kind of slows things down. So, if the patient can only get imaged when they're taking a breath, it slows down. And in our facility, because we were, one of the first places to have cone beam CTs on a proton machine, I think our CBCTs are probably slower than most others that are out there. And Jennifer can maybe comment on that during her portion of the talk. But I will say that using CBCTs in breath hold in the Proton Center is particularly challenging, although you can realize the value of doing that. And then one other thing about proton therapy is that, it really does not do well when there's variation in the density through which it travels. So this uncertainty will kind of lead to what I call over planning, where you're trying to take into account for what might happen. And I will say that most of the proton cases that we treat in the liver, we do use the abdominal compression belt when we're using pencil beam scan, which is really everything we're doing now in our proton center. So I would say that, liver tumors are one of the more challenging sites, but I think quite rewarding because they do respond to radiation if you go to a high enough dose. But this is one of those areas where I don't think we have it all figured out. All right, so I want to change gears and talk about unresected pancreas cancer. When I was training, most of the pancreas cases we treated were post-operative. There's been a pretty strong trend moving away from post-operative radiation, and they're just getting chemo now for the most part. But the places where radiation still, I think, has a role is in the unresected cases. Nowadays, they just get chemo until they have some side effect that they can't tolerate, or if they have progression on all the lines of chemotherapy, that's when they send them to us. So we've been treating a lot of what I would call kind of larger and more challenging unresected pancreas cancers. And the best way of doing that is certainly evolving. I do believe that getting higher doses in than sort of the 50 gray that we may have done in the past is required. And so you try to get as much radiation dose into the actual tumor as you can without hurting anybody. So the duodenum, which kind of wraps around the pancreas, is usually the OAR that causes the most problems. And then the second one is usually the liver. And so what this requires is really precise localization, and therefore holding it still is of value. So this is a patient with unresected pancreas cancer that we treated with deep inspiratory breath hold and IMRT using a mild hypofractionated approach with 52.5 gray in 25 fractions. So if there's a line on the screen, I don't know if anyone can figure out how to get that off. But at any rate, so I'll proceed. So this is a coronal view of a patient with pancreas cancer, and I just want to show sort of how that moves. And it's a little bit hard to see, but the tumor itself is right next to this lower clip, and between inspiration and expiration, you can see that that's moving probably close to a centimeter. And in this case, we thought it made sense to treat this patient with breath hold. They were able to tolerate it, and so that was the case I showed you a second ago. I would like to point out that even when you are doing breath hold, there is motion, and I would direct you to this paper by Dr. Zhang, Interfraction Tumor Motion During Deep Inspiration Breath Hold Pancreatic Cancer Treatment in Journal of Applied Clinical Medical Physics that came out a couple of years ago. And they kind of showed some really nice studies on how the pancreas moves even in breath hold situations. And so this brings me to kind of an important point of how you draw volumes, which I will talk about when we get to the mediastinal lymphomas part, but it applies for GI cases. Okay, so just to kind of summarize GI, it's mostly used to limit motion. You try to get the dose up as high as you can. You create very steep dose gradients, and then good use of IGRT to confirm the position of both your targets and your OARs if you can. And then the fiducials can be helpful to really make sure that you're sure where your tumor is. Again, the older and sicker patients are going to struggle with this, and so having some other backup plan I think makes sense. And again, we use abdominal compression devices pretty heavily at Penn. Okay, so I'm going to shift gears completely and talk about lymphoma. So hopefully you guys, if you have questions, you're putting them in the chat. But I want to talk about breath hold for lymphomas, which is, I think, a very interesting area because it's not just about keeping motion down. I want to take a step back and talk about radiation for lymphomas, since I think most people probably don't treat a lot of lymphomas in your centers, given the recent trends. Really, the medical oncologists have relied more on systemic therapies, and radiation, when given, I think should be given quite selectively. Acknowledge that we do create late toxicities, and there's being very stringent with our treatments when we do them. So we use the involved site radiation paradigm. We use all the technologies at our fingertips to get those doses to the OARs as low as possible. Because these patients are going to live a long time. They're going to live for decades. Even low doses plus 30 years is going to cause toxicity. And we just have to recognize that and not pretend that it doesn't exist. And really the things that I focus on are cardiac toxicity, pulmonary toxicity, and obviously second cancers for these young curable patients. So cardiac toxicity, I personally don't believe you should just stick to the mean heart dose. Sure, we look at mean heart dose, but I think there's a lot of subparts to the heart that can experience toxicity in different ways. We obviously know about the vessels can get accelerated atherosclerosis and coronary artery disease, but the muscle may behave differently, the pericardium may behave differently, and the valves can scar down and cause valvular stenosis, which is actually one of the most common cardiac late effects. And then something that I think is underappreciated is the conduction pathways. We've learned that we can manipulate these conduction pathways recently using SBRT, but we've been damaging them for years and years. And if you talk to medical oncologists who take care of Hodgkin patients who were treated back in the day, they'll say one of the main things is issues around the conduction system. And so, I think that it's more complicated than just a mean heart dose. So I would encourage you to think about the heart as a complicated organ. Regardless, we do know that mean heart dose does correlate with increased risk of of heart disease and events. And it's quite similar to the breast cancer in terms of the actual risk. So 7.4% per 1 gray is actually almost the exact thing that you got from that Darby paper. So we pay a lot of attention to the heart in lymphoma. So I don't just stick with mean heart. As I mentioned, I do draw cardiac substructures, or if I have a resident working with me, they draw them. And they all know that I like to see the aortic valve and the coronary vessels, LAD, as well as the left ventricle. So I think that it's important to share what's important with your dosimetry and physics colleagues so they can make a plan that doesn't go through one of these smaller substructures if they don't need to. And then pulmonary toxicity, most people think about radiation pneumonitis from lung cancer, but it does happen in lymphoma, and it may happen a little bit differently because of the chemos that they get, which are pretty heavy duty actually, given right before the radiation for the typical combined modality case. And so there's some parameters out there that have been developed. And Chelsea Pinnock's wrote this paper in 2015 showing kind of what happens with IMRT and pointing out that the V5 we think actually might be important in lymphoma compared to what people might think about in lung cancer. So there are guidelines for doses out there for pneumonitis. And then again, second malignancies, this has been a big story for a long time. And so we do everything we can to not put, non-target tissues in the way of the beam. And this is a lot of why we use proton therapy. But if you are going to use IMRT, I think it makes sense to do this with the deep inspiratory breath hold in order to do your very best to limit dose to any OAR, whether it's the breast, the lung, the thyroid, the esophagus, whatever it might be, all of them happen. Okay, so this is a case that I like to show residents when I do visiting talks. This is an example of a DVH, and I ask, would you ever approve this plan? You have a mean heart dose of 14.5, mean lung dose of 15 gray, your LAD's getting a mean of 32 gray, the breasts are getting 11 and 13 gray. And if I saw this plan, I would say, no way, I'm not treating that. We have to find a better way. But what is this actually? So this is sort of a mock-up of an APPA modified mantle field. And yeah, it's pretty awful. If you look at that, you kind of just gasp and say, oh my gosh, I hope I never have to treat that. But this just points out that, radiation for lymphomas has evolved So on the far left, you see, a typical mantle with the bilateral axillae, the modified mantle where the axillae were dropped out. In the middle, what we might have called involved field, and then C, where you just treat where the tumor was, with sort of margin for trying to figure out how it shrunk down. Was what we call involved site radiation. So we are definitely changing the volumes that we treat, and that's probably the most important way of decreasing toxicity. So ISRT has been defined in this Ilrog paper that came out in 2014, and it's really the standard now. And it basically allows you to do all the stuff that we've been doing for everyone else. So when I trained, we like drew with crayons on X-rays, and we treated everyone APPA. Now we do CT-based simulation. We use ICRU definitions for GTV, CTV, the ITV, PTV, and we come at it from any way we can to limit the OARs. So this has been kind of an important change in the treatment of lymphomas. And so these more conformal techniques have allowed us to basically model, fewer life years lost due to radiation. So even though there's been less radiation used, we actually have more ability to use radiation now. So it's one of those things where it's an education issue, and we really need to beat the drum that we can do awesome stuff. The Ilrog published this guideline for proton therapy with a nice table on the target doses. Even though it says it's proton therapy, this is what we use in our photon clinic as well. And they're pretty tight constraints. So I would encourage you to use these. But coming back to the breath hold issue. So in free breathing, you see where the diaphragm is and the size of the lungs. In breath hold, you get the heart down and the lungs larger, and allows you to really decrease the dose to the heart and lungs. So when we treat patients in our facility, we do use a 5-point mask, chin hyperextended, and we use the 5-point mask to make sure that the shoulders are really well stabilized, because often our targets sort of are near the upper mediastinum and necks. We do cut out the face, so it kind of looks like that chainmail look, which allows then the SDX system to get in there with the mouthpiece, the nose clip, and the goggles. And then just to see the effect of breath hold on the target. So in the top panel is free breathing of a 14-year-old male who had stage 2 classic Hodgkin lymphoma, who was being treated after chemotherapy. And you can see that target is quite wide in the free breathing, but when you do breath hold, it skinnies it up, and all of a sudden you're dealing with a much smaller target, which can also help decrease your lung dose. And then the heart will also move kind of down and away from the target. So I've highlighted on there in pink the left main coronary artery. And although the contours don't really reflect that between the left, which is free breathing, and the right, which is breath hold, because I didn't recontour it on the free breathing, I think you can imagine that those OARs are kind of up closer to the target. And so I think those are the main reasons that we really do insist on breath hold in pretty much every mediastinal lymphoma case that we treat. So as I mentioned, I want to explain how we build our volumes. So, we usually start with our GTVs, and then the CTV is defined in ISRT based on the, places where you think the tumor was before it shrank down. I'd like to point out that even though we are using breath hold, we do create an ITV. Because as I've mentioned, even if you're in breath hold, you're not going to hit to the same spot every single time. And there's a couple of different ways of creating an ITV. You can do multiple scans in breath hold to try to get a sense of the variation, or you can just kind of make an estimate of what that might be based on the motion. So I get a 4D scan as well and see how the mediastinal masses move. And if I estimate that there's variation of the diaphragm of, say, up to a centimeter, what is that going to translate into when you're at the mediastinum? I think we're actually a lot better than a centimeter, but I kind of take that sort of what I call the worst case scenario. But it ends up being about a 1 millimeter radial expansion in the mediastinum with maybe 2 millimeters supinimp to go from CTV to ITV. And then on top of that, we generally use a 5 millimeter PTV. A lot of people just will go straight from CTV to PTV to include that ITV motion, but because we're a proton center, we do plan to the CTVs. So we try to make that CTV or ITV the correct volume. In this case, this young kid, we were able to achieve a plan with a mean heart dose of, a little over 3 gray and a mean lung dose of around 3.5 gray, which is pretty awesome. So this is an example of a proton case using a cone beam CT to verify the position. So the bottom right panel is the proton cone beam CT. So not great quality, but enough to get the job done to establish that, we have our target where we want it. Here's a sagittal and showing, when you sort of match that up to the lung outlines, that you're in the right place and your breath hold is in a verified position, which I think is really important when you're doing proton therapy. Okay. So there's been quite a bit published on the value of breath hold in proton therapy in lymphoma, and I'll kind of summarize it in that, excuse me, in that the combination of breath hold and proton therapy is the best for reducing organs at risk, but IMRT with DIBH is pretty good. And so if you only have, IMRT, then you really should be using DIBH if you can for your mediastinal lymphoma cases. There are a few exceptions to that, of course. This is a paper that Brad Hoppe published in the IJPT, showing that some cases when you had very low cardiophrenic disease, you would actually potentially have plans that were maybe a little bit worse with breath hold. This is an interesting paper. There's just 3 cases, but I would say that in our clinic, we're actually treating very few patients who have disease down here anyway with combined modality. They're mostly getting chemo-only approaches. But just be aware that, when you're treating mediastinal lymphoma, if you're at the diaphragm, those things really are going to be less reproducible, and you actually may kind of create a longer field. So that's the one time where I hesitate to use breath hold, is when you have cardiophrenic disease. Right, so, if we think about, the radiation techniques for lymphomas, I think in general, DIBH, proton therapy, to me is probably the best solution for most cases. I mentioned the DIBH being questionable in low pericardiac disease. If you're combining both, you really need to be careful about making sure your breath hold is in a reproducible position. As one of the reasons I actually like the SDX system, because it is, I think, quite reproducible, because you're measuring lung volumes as well as just a position of like a fiducial sitting on the diaphragm. Do you think that we need to continue to evolve this? There's plenty of room for improvement for sure. And I think the big step for the physicians out there is, you need to make these decisions in the multi-D clinics and going into tumor boards and saying, wow, that's a terrible radiation case, and I think we should just do chemotherapy only. I think that's probably the best way. So briefly, I'm going to just talk about gastric malts. So in this case, the actual target is the stomach. The stomach is going to move a ton with breathing. The stomach also may expand if it's not totally empty. So you have to take a lot of care to do these cases. But there is a presentation at Astro in 2018 that showed that you actually can get some distance between the stomach and the heart if you use deep inspiratory breath hold. And I see if this video works, so this will kind of pan through. So you see on the left, you have the breath hold. On the right is the non-breath hold. You can see you can kind of develop this space in between the heart and the diaphragm. So I'll run through that one more time. So if you can kind of focus on that space that's created between the stomach and the heart. So this may be less relevant as we are using lower and lower doses in gastric malt. We're kind of going down to maybe 24 gray. There's a trial at MD Anderson looking at 2 gray times 2 for gastric malt. So we'll see how that turns out. But in the meantime, I've been using breath hold for gastric malt cases as well. All right, so to summarize, I think DIBH can be helpful in GI cancers by limiting that motion, reducing the size of the target by limiting the sort of ITV, and allows you to do that dose escalation with steep dose gradients. It's definitely limited by the ability to do good onboard imaging, because the abdomen often is tough to see what's going on. So we use fiducials when we can, and obviously a lot of CBCT. And then again, the sicker and older patients may not be able to cooperate as well. We certainly have had some of our older patients who have a hard time with the goggles with our system. So, it's one of those things where hopefully, the systems will improve and make things easier for the sicker patients. In the lymphoma world, DIBH can also limit motion, which is great. But I think you get that extra advantage of displacing the OARs away from the targets, very similar to what we do in the breast cancer clinic. We're certainly limited by good onboard imaging, and I think this is particularly an issue in proton centers where it might be a little bit slower. And then again, when we use a lot of proton therapy, that sensitivity to position can be a downfall. So that being said, we definitely use breath hold a lot in our GI and lymphoma clinics. And when we did a quick survey of who was on breath hold in our department just the other day, I think we have, about 30% of the patients are breast cancer patients, and the rest are GI and lymphoma patients. So this has been kind of, exploding since we first got used to it in breast cancer. So I'll turn things over to Jennifer, who, there you are, and I'll let you do your slides.
Thank you, Dr. Plastaras. Okay. All right, Dr. Zhao, you next.
Okay, so let's see if I can control my screen.
Did that work, Jennifer? I gave you control.
Yeah, so let me see. Okay, yeah, it worked.
Okay, good. All right.
Hi, thank you, Dr. Plastaras, for the wonderful talk. So for the rest of the session, I'm going to talk briefly on our technical consideration using SDX DIBH in our clinic. So the general overview of the motion management, because we care about the proton beam, how they are sensitive to the radiological path length changes. So we want to try to immobilize the target as much as possible in order to limit anatomic inter and intrafraction variation. Okay, so the methods to mitigate the motion, as you have heard, may be sensitive to the technology and the site specific. And this technology should be carried out through the treatment, including the simulation, treatment planning, and treatment delivery. So our center is now exclusive pencil beam scanning center. We do not have passive scattering anymore. So the scan beam are very sensitive to the moving target. It's called so-called interplay effects that talking about the interplay between the patient target motion and the dynamic treatment delivery from spot to spot and layer to layer. So sometimes we to avoid the organ at risk dose, so we try to use multi-field optimization. Compared with single field uniform dose treatment technique, this technique can be more sensitive to the interplay effect. If we want to treat the target with hypofractionated scheme, with larger dose per fraction and the larger MU per spot, the dose distribution in the target can be more sensitive to the motion. So the effects usually caused by the organ motion is because we can miss the distal range of the target, and we compromise the lateral dose conformity, and we create some dose heterogeneity bands in the target, for example, underdosing and overdosing. So in our treatment of large center, we have both pretty busy photon and the proton clinic. We want to select the motion management in a fashion that they're effective and they're easy to use and should be applied to both proton and photon patients. For GI cancers, we typically use SDX DIBH or compression belt. The reason to use this is to reduce the target margin and then reduce the normal tissue toxicity. So what shows here is typical what the physician prescribe for the motion management. So we would like to first try SDX if they can be tolerated by the patients or the patients can follow the instruction. If it doesn't achieve the goal, and we will apply compression belt to the patient. If the patient still cannot tolerate this device, we will perform the free breathing 4D CT to the patient. That will result a larger target margin. So the SDX is a spirometry-based voluntary breath hold device. So it comes with a video goggle that patients wear to see the software display, same as what the therapist displays, so they can synchronize during the breath hold and the treatment. So before simulation, we typically have a 30 minutes training session that conducted by the therapist to the patient to get the patient familiar with the device and measure the patient's breathing capacity, and then teach the patient to follow the cue on the screen. So in our facility, we use the setup on the left that consists of a sensor integrating a removable honeycomb tube, and with a filter and a mouthpiece plug into the patient mouth. The nose clip is to prevent actual airflow through the nose. So in our facility, we do not use the respiratory facial mask setup. This is just a close-up look about what the patient setup looks like with the tube and the mouthpiece and the nose clip and the goggle. And on the right is what patient sees and the therapist sees. So the curve of the red is patient take a few free breathing cycle before they take deep inspiration, and then when the volume reaches a certain threshold, we can conduct the CT simulation and treatment. Patients usually takes 3 or 4 consecutive breaths in this gray stability zone before they take a deep breath hold as instructed by the therapist. So they see a green light that signals them to inhale, and the red light signals them to breathe normally. So the left shows what the screen shows in the CT simulation, and then the right shows what the treatment is. So usually our proton beam can take 1 or 2 minutes to deliver. So the patient should take about 2 or 3 or more episodes of breath hold before the treatment can be finished. So to show you the connections, in our facility, we actually have, in our current center facility, we have 5 SDX DIBH system. So some LANAC rooms have this particular point-to-point Ethernet connection that connecting the SDX trolley and the SDX device in the vault with the computer sitting in the console area controlled by the therapist. Due to some historical reason, we also have freestanding SDX cards with the PC connected to the Proton, CT, and some LANAC rooms. So the therapists actually control those computers via VPN connection. So the important thing here for the connection is we build the patient database on a shared network drive. This is to share the patient information between the CT simulation and the treatment. And one more important thing is if the patient has to be treated with photon backup plan, in the case that Proton machine goes down, that the patient database is not going to be disturbed. Okay, our therapists perform daily calibration checkup using a 3-liter syringe, and they just do a 3 peaks that shows on the bottom right. And then this is a pretty simple daily checkup. One caveat to this is we have to allow 5 minutes of stabilization time zone to pass before conduct the check. This is to wait for the sensor temperature to stabilize. So sometimes it can, if we don't wait that long, it can cause the daily checkup fail. So that's how we start our physicists, when we help the therapist, that's the first thing we do. Okay, so this is just show you that can fail, and then if they stabilize long enough, the sensor stabilize long enough, it will pass. Our simulation, just as other centers for Proton centers for simulation, we want to reproduce the patient positioning. It is crucial for Proton treatment. And we want to create some immobilization that has a well-defined and uniform water equivalent distance. And the immobilization device should be rigid and ideally have low density material along the beam path. So this picture shows immobilization with a patient scanned for liver cancer. So the patient is situated in supine position with arms up. They can hold the PEG pins, or they can hold also the device bar the SDX device bar. And then they use the wing board to immobilize the shoulder position and the head in a neutral position. And we also use index knee block to position the patient legs. So after the patient coaching session, which usually lasts around 30 minutes, we generate this document that the patient is capable of performing breath hold. We also determine the lung volume, and we use 75 to 80% of that volume as our gating threshold we recorded here. For this patient, they can do max, we recorded their max breath hold duration. And also we make a comment that what the patient preference about the breath hold duration. And we also document if the patient wants to use video goggles, or if not, they can listen to the audio instruction from the therapists. And we also document the patient being color blindness or having breath disorders, breathing disorders. Okay, in terms of the treatment planning, it is same as other proton treatment planning techniques that we want to use the shortest beam path to target to avoid the range uncertainty. And we want to use a homogeneous and reproducible path to the target. So we try not to have the beam stop at proximal to the critical organs. If that happens, we typically use a couple other beams to mitigate the risk. One particular to using SDX DIBH system is to avoid potential collision with the mouthpiece with the gantry nozzle, especially with the, when you use the range shifter. So currently our treatment planning system are pretty well at detecting the potential collision as long as you include that mouthpiece in your body contours. That's essential for detect potential collision. So the other thing to pay attention is we want the beam not pass through the mouthpiece before reaching the target. So in this case, we use a beam specific target that is superior portion of the target that we use posterior beam to irradiate. And then we also use some anterior beam to irradiate the lower portion of the target. So if your anterior beam cannot completely avoid the mouthpiece, you might consider using the couch kick and using some inferior oblique beams to irradiate the target. In terms of image-guided image-guided treatment, in our system, we have this orthogonal X-ray imaging system set up that can pretty much set up the bony anatomy. To get a soft tissue contrast, cone beam CT can be considered. So our center is the first that implemented the proton cone beam CT, that we have this X-ray tube mounted along with the gantry rail and rotate with the gantry. So the field of view of the cone beam CT is 34 centimeter by 34 centimeter. And the rotation speed is 0.5 or 1 rotation per minute. You can see this 30 seconds or 1 minute is longer than the patient treatment hold. So we typically allow the patient to hold about 2 breath holds. We pause during the cone beam CT collection before we implement the entire cone beam CT collection. So for the GI cancer, we typically do a half scan. Okay, this is to show how well the setup is if we implement the cone beam CT. This is for the liver cancer, and with this SDX DIBH hold, the setup is pretty reproducible compared with the planning CT. In our facility, we also perform verification scans. Typically, we use CT verification scans every other week, about 5 to 10 fractions apart, to detect any organ at risk or target motion or patient anatomy change, such as gaining or losing weights. So cone beam CT can be additional verification checks along daily to effectively detect such change if the patient can tolerate the scan time. So with this, I'm going to finish our talk and welcome questions. Thank you.
Thank you very much, Dr. Yao and Dr. Plastaras. Very excellent, very detailed and excellent presentation. So we have a question from the audience. This is a question from Dr. Ann Liu from City of Hope. And the question is, instead of using DIBH or deep inspiration breath hold, can we use the end of expiration breath hold for liver and pancreas?
Yes, I think that's fine.
Yeah, so I guess depend on the purpose. For the thoracic, for the lung, when you do DIBH, you have increase the lung capacity to reduce the percent of a lung gut radiation. But for liver and pancreas, DIBH can actually distort the organ more and make it more uncomfortable, right? Just like your presentation mentioned. So what the threshold you use for the liver or pancreas on average?
Which what?
What the threshold you usually use for the patient for the liver and pancreas?
Like a threshold.
About 50%, 75%.
Of how much of the maximum? I think we do 75, right, Jennifer?
Yeah, 75 to 80%.
Yeah.
Even for liver and pancreas.
Yeah.
Okay.
So this is really for the patient to be able to hold about 20 seconds or long for the treatment. If they cannot reach that, we will consider compression belt.
Okay. Now, in your system, do you have the beam interlock built into the system so the patient fall out the threshold, the beam stop automatically, or this has to be intervened by the therapist?
Yeah, we all manually intervene through the therapists.
Yeah, it's manual. The therapists have to keep their jobs, I guess. I don't know. Yeah, it's all manual.
Okay. So yeah, because in the Proton Center in San Diego, we used to have that manually intervene by the therapist, but it takes about 12 seconds when you push the pause or the stop for the beam to actually stop. I think the SDX have a new system, new module now that you can basically directly into the beam interlock system. So as long as the graphics show the beam out of range, the beam pauses directly. Is that correct, Annabelle? Is the system available for IBA and for Matheon?
Yes, Dr. Jab. So the synchronization option is available for IBA, Varian, Matheon.
Okay. So is this new? Is it released recently? Is the last 6 months or a year or so?
The gating module for the IBA and Varian have been around for quite a few years now, and we just started working with Matheon for the Matheon S250i. So we're going to announce great news very soon.
Okay. So this is a box device, right? You connect directly with the beam interlock, so that way they take out the therapist intervention. Basically, as long as the patient stay in the green zone, the beam go on. It will stay out. The beam pause, right?
That is correct. It's a box that is very similar to the SDX module, and it will be connected to the UBTI or to, for example, for Varian, for the TrueBeam, it's the MMI. So it's basically what allows the interfacing to the machine, and it will trigger automatic beam on, beam off with the machine.
Yeah, I have a question for Dr. Plastaras and Dr. Zhao again. Do you have like the separate imaging system like the Vision RT or CRAT at your center? And do you have experience combined with this system?
We used to have MRT, but we don't have it. We don't use it anymore.
Okay.
The reason is right now we majorly use the SDX DIBH and the compression belt is because they are actually effective and they're simple and then easy to use. And then it's, for our busy center, we do not want to create the chance for mistake or error treatment. So this, as long as they're effective, that's what we use.
Yeah, we do have some of our centers, in the region are using the automatic breathing control breath hold systems, but we have kind of a mix. I think most of the regional centers actually are also using the SDX system, but we do have some mix in our health system. I remember trying to do the Vision RT. I think the big trick was trying to make sure that with the Proton Center and all the other jazz that goes around it, trying to get the right camera angles. And I know that when I visited the Proton Center in Groningen, that was what they were working on with the Vision RT. I think they did figure it out eventually, but it was quite a bit of work to find just the right camera angles for the Vision RT.
Okay, yeah, we have a few more questions from the audience. The next question is, do you screen your patient for DIBH for GI side, and if so, how you do it?
So we do a little bit of a clinical screen first. Sometimes you'll just see them in the clinic and the nurses and I will just stare at each other and we're like, there's no way. So there's that initial screening, and that probably, I would say, cuts out probably maybe even like 20% of the patients that you just know they aren't going to be able to do it from the start. Then we do have a training session that Jennifer mentioned. I think we actually have them blocked for a full hour, but I think it usually only takes about 30 minutes for them to do the practice session. And that's really done hands-on with the therapist. And they'll sometimes, call over the doc and say, hey, they're kind of on the borderline, this is what they can do. But by and large, that's a radiation therapist decision whether or not they can actually get through it or not. And I do trust my team to make those judgment calls. I think every time I've said, I think they'll be okay, I think I've always been proven wrong in the end. So I've learned how to trust my teammates.
I guess it's called experience. Yeah. Another question is, do you do volumetric repainting with motion management?
We just started in some patients that has very high MU, that we split the beam into two fractions and deliver side by side.
Yeah, I've seen cases even when we have like 2 beams that they'll actually break it into 4 beams.
Yeah.
So yeah, I think selectively. I think most of the time though, if they have 2 or 3 beams, you kind of already get that repainting kind of built in.
I see. Another question is that possible to deliver a single field with 500 cc volume within a single breath hold?
5 cc's?
500 cc, yeah. Half a liter.
I think, so I guess it's a kind of a proton question, right, Jennifer? Like how fast can you paint a PBS field? And yeah, I think it all depends on how long they can hold their breath. I feel like you're right. I think it's almost always at least 4 breaths, for patients who are actually doing the treatment, and a couple more for imaging. I don't know that we could do 500 cc's. What's your estimate on that, Jennifer?
Yeah, I mean, it really depends on, the most of the time really spending when you have a lot of layers, like energy layers. So if you have a deep, like a large tumor along the beam path, then the distance is long, so you have to use multiple energies. So each energy switch is 2 seconds, or around 1 second, 1 to 2 seconds. So that really build up the whole the entire time. So I mean, if just like a large area, but with a pretty shallow distance in that beam path, so you can do with 2 or 3 energies, then you probably should be able to deliver. I think it's really tumor shape dependent.
Okay, yeah, I have one question. When you do the simulation with patient, you do the CT scan multiple times to see there's a drifting of a target even with same setting?
So we have talked about what's the best way of doing simulation, doing sort of multiple breath holds and then kind of doing like a MIP type projection. And that's kind of like the MGH style. We honestly had been for many years very tight in CT time. And so we ended up doing sort of more estimated ITV expansions rather than doing multiple CTs. It's still on the table. Nate Anderson and I have kind of banged that idea around. Should we be doing like 3 breath holds? And I think Nate's point is like, well, that will tell you how they're doing on that day, but you bring them back and it might be a different, sort of factors that changes the position of the breath hold. So I think doing the onboard imaging makes sense. There's one point I wanted to make and I completely forgot to make it, and I thought of it while Jennifer was doing her talk, which is this idea of bony landmarks using the KVKVs. We actually can often see the top of the diaphragm just with the like PA the KV beams. And what we will do is put on a diaphragm OBI structure for like the mediastinal lymphomas to sort of just say, yes, is the diaphragm in about the right position? Even if you don't get like the full CBCT soft tissue, you can at least get the diaphragm.
Yeah, I have talked to some center that for liver treatment, they actually put fiducial marker in the liver, and they do do this several times to measure the rifting factor from the fiducial marker to create the PTV or ITV per se. What do you think about that?
I think it's a great idea. Yeah. I mean, I don't know that we have everything figured out at all with liver. It's such a complicated site. And I think what we've tended to do is end up sort of treating a little bit larger volumes than we would like to. I think as your technology gets better, we've found ourselves, being able to be a little bit more tight as we're more sure about where we're treating. When we were doing only double scatter, I think we were treating huge swaths of liver, to be honest. But I think over time we're kind of refine a little bit. I think that's a really good idea, though. I will say, unfortunately, at Penn, our interventional radiologists have been a little bit shy about putting in fiducials. They'll do it, but they had at least one patient who ended up having hematobilia. They basically hit a vessel when they're putting in a fiducial, like early on, and so they're like, "Oh, do you sure you need the fiducials?" And so we do also get many patients who have been treated with Lipiodol. So we must always have a radio-opaque internal marker in the form of the Lipiodol on almost every patient we treat. Juan, it's almost like every patient has gone through chemoembolization first before they'll even think about sending them to radiation.
Yeah, I don't have any more questions left. I guess one question for you too. If you have one thing on the wish list that you ask, DYN'R SDX to do for you, one improvement, what would you do? What do you ask them for? What is the one feature you would ask them for the next version that they have?
Jennifer, what is your thoughts on that?
I didn't ask that question before.
You happy with your system? Do you have anything else you want to add to it? Okay.
At the risk of being impolitic, I will tell you what I would like is a better visual sort of system. I think that one of the biggest limitations we have are being able to see in the goggles. Sometimes people just can't quite get it right, and depending on their vision. And so I saw this super cool presentation at PT Cog NA that they're using for pediatrics, where they're trying to get them to use less general anesthesia. And they had this like little curved screen that went in front of the patient and an iPad that projected the vision, the images of like Disney movies, so they could, do treatment without general anesthesia. I think if you had a visual interface that was a little bit less clunky, I think that would be an improvement. And then if you want to know what I want in our Proton Center, I want a faster CBCT. So.
Okay. Yes. No, I think that's a good feedback for DYN'R SDX. But anyway, so I think that's the end of our presentation and question. We run 10 minutes after. But this is an excellent presentation, and I learned a lot. Thank you very much both for doing this.
Thank you.